High risk, high stakes, and emotionally demanding, a diabetic foot patient for above knee amputation. We invite Dr. Thomas P. George, Professor and Head of the Department, Anesthesiology, Pushpagiri Medical College Hospital, Tiruvalla, and Dr. Paul O. Raphael, Professor and Head of Department, Anesthesiology, Malabar Medical College, Kozhikode.
We have Dr. Ostrich Benny and Dr. Christy Hannah John from Pushpagiri Medical College Hospital, Tiruvalla to present this case.
Let me thank ISA Midcon 2026 team for allowing us to present this topic, that is diabetic foot for AK amputation. As a silent internal examiner, I will not ask any question. The external, Dr. Paul will ask questions. If our PG fumble, I will help. Okay?
Okay, thank you, Thomas. I'll oblige for that because he was the examiner in our institution last time. He was the external examiner. Can you introduce yourself?
My name is Ostrich Benny.
Dr. Christy John.
Okay. Can start with the case.
A 62-year-old female who is housewife by occupation hailing from Tiruvalla came with the complaints of non-healing ulcer over right foot for the past 3 weeks, discharge from the ulcer for 10 days and black discoloration extending up to right knee for the 3 weeks. History of presenting illness, a non-healing ulcer which increased in size and is not healing despite medication, pin and needle sensation bilateral feet, black discoloration extending up to right knee, fever for 2 days. There is no history of cough, burning micturition, diarrhea or syncope. Past history, she is a known case of type 2 diabetes mellitus for the past 15 years, poorly controlled, is on OHA and insulin therapy and she is non-compliant. She was on tab, metformin 500 mg BD and humatrapid 15-010 sub-Q. There is no history of similar ulcers in the past, no history of chest pain, dyspnea, giddiness or vision loss. She has feeling of pin and needle sensation in bilateral foot. On general examination, the patient is conscious, oriented and anxious, no pallor, icterus, cyanosis, clubbing, lymphadenopathy, pedal edema present, right foot. Airway, mouth opening adequate, Mallampati grade 2. Neck movement, atlanto-occipital, temporomandibular and cervical spine, there was no restriction. Prayer sign negative and palm print sign grade 0. Vital signs, heart rate 100 per minute, which was regular, normal volume, character and wall thickness. All peripheral pulses were palpable except the dorsalis pedis. BP on sitting was 130/80 and on standing 100/60 mmHg. Respiratory rate 18 per minute and saturation 99% in room air. Temperature 100 degree Fahrenheit. On local examination, inspection of the right foot, an ulcer of size 10 into 8 cm was present over the right angle. Margin was punched out. Floor, pale and healthy granulation tissue with slow and necrotic tissue. Discharge and skin changes were present. Black discoloration extending to right upper knee. And on palpation, it was non-tender, indurated base of depth 2 mm, reduced sensation and peripheral pulsation dorsalis pedis was absent and posterior tibial was feeble. On systemic examination, CVS S1, S2, no murmurs. On respiratory system, air entry bilateral equal. GIT, no organomegaly. CNS, higher mental function within normal limits. On peripheral nervous system examination, bulk and tone normal. Power 5/5 all limbs except right lower limb, which was 4/5. Reflex, right knee jerk sluggish. Sensory, decreased pinprick and vibration sense. So summary, a 62-year-old female who is a known case of long-standing type 2 diabetes mellitus and is on irregular treatment with OHA and insulin therapy is now admitted with fever for 2 days and non-healing ulcer near right foot, which increasing since 3 weeks, which was associated with absent pulsation of dorsalis pedis, decreased vibration sense and orthostatic hypotension, is now posted for AK amputation of right foot.
Okay, so your patient is a diabetic patient for amputation. So can you tell me what is diabetes or how will you define diabetes?
Diabetes is a metabolic disorder which is characterized by chronic hyperglycemia due to absolute or relative insulin deficiency or insulin resistance, impairing carbohydrate, lipid, and protein metabolism.
What is the diagnostic criteria to say that it is diabetes?
According to ADA criteria, if the FBS is more than 126 milligram per deciliter and RBS more than 200 milligram per deciliter with signs, symptoms of diabetes, and if the HbA1c is more than 6.5%.
So what is the full form of ADA? This
American
also-
Diabetic Association.
Okay, can you tell us what is the pathophysiology behind this, in this condition?
So there is a lack of insulin which is leading to increase in the secretion of cortisol, glucagon, growth hormones and catecholamines, and there is increase in the catabolism leading to increase in the gluconeogenesis, glycogenolysis and lipolysis, which leading to hyperketonemia and acidosis. There is decrease in the anabolism leading to hyperglycemia, glycosuria and osmotic diuresis, where followed by the patient will present with polyuria, polydipsia, hypotension and tachycardia.
Okay, as per the ADA classification, as per the ADA, what is the classification of diabetes? How will you classify diabetes?
We have 4 types of diabetes mellitus. Type 1, there is absolute insulin deficiency due to the beta cell destruction, which is again divided into type 1A and 1B. 1A is immune mediated and 1B is idiopathic. Class type B, it is relative predominant insulin resistance with relative insulin deficiency. Type B, it includes other types, that is drug induced, syndrome induced, then genetic defect of the beta cell function, genetic defect of the insulin action, disease of the exocrine pancreas, endocrinopathies, and type 4 is gestational diabetes.
How will you differentiate type 1 and type 2? And why do you want to differentiate this? Why do you want to know the type of diabetes?
So that we can differentiate with whether it is an insulin dependent or insulin independent. Type 1, it is insulin dependent, and type 2, it is insulin independent. Based on the onset, type 1 DM, they are usually sudden in onset and seen in the younger individuals. Type 2 DM, they are gradual in onset and seen in the adolescent age groups. And endogenous insulin is absent for type 1 DM and it is present for type 2 DM. Autoantibodies are present for type 1 DM and type 2 DM it is absent. And prevalence rate, it is 90 to 94% it is type 2 DM, whereas 5% is for the type 1 DM.
Slight correction is there. Insulin, type 2 is insulin
Independent.
non-dependent. Okay.
Okay, you said about the drugs which can cause. Which are the drugs which can cause diabetes?
Oh, it is an insulin, sir.
And you mentioned about, no. What I meant was drugs which will induce.
Okay,
induce
antiretroviral
that.
drugs, thiazide, glucocorticoids, beta stimulants.
Thiazide diuretics, yeah. And you mentioned about the endocrinopathies. Which are the endocrinopathies which is associated with diabetes?
Cushing syndrome, Addison's, hyperthyroidism, somatostatinoma.
Is there any syndrome associated with diabetes? Any syndrome you know of?
Syndrome X, which is a cluster of symptoms like insulin resistance, accelerated hypertension, dyslipidemia, and central obesity.
So it is metabolic syndrome. What are the adverse effects of hyperglycemia? And if left untreated, what can happen?
If it is left untreated, the patient is more prone for poor wound healing, myocardial ischemia, that is silent MI, infections and renal dysfunction. Also, they can present with dehydration, acidosis, electrolyte imbalance, fatigue and muscle wasting.
So when you are taking the history and the examination, what are the points you would like to ask the patient and examine and elicit also?
We ask for the duration, the type and the severity of the diabetes mellitus the patient is having, the medication the patient is taking, the regimen he is following, if there is any complications of diabetes, the test for autonomic neuropathy, the test for difficult airway.
Can you tell what are the complications which can occur?
There are acute and chronic complication. Acute complication includes hypoglycemia, diabetic ketoacidosis, then hyperosmolar hyperglycemic state. And the chronic includes macrovascular and microvascular. Macrovascular, coronary artery disease, stroke, POVD, which mechanism is atherosclerosis and increased coagulability and impaired fibrinolysis. Then microvascular complications, diabetic retinopathy, nephropathy, autonomic neuropathy and peripheral neuropathy, which is due to osmotic stress due to sorbitol accumulation and free radical production.
Diabetes is considered to have airway issues. What is it and what are the issues which can happen and how can we predict it?
Airway issues that is seen is the stiff joint syndrome or limited mobility syndrome. This is mainly due to the non-enzymatic glycosylation of protein and abnormal cross-linking of the collagen, leading to impaired limited mobility of the cervical spine, atlanto-occipital joint, temporomandibular joint, and cricoarytenoid joint. So we have two main tests. One is the prayer sign, where we ask the patient to oppose his palms and the fingers as we do in the prayer, and the patient will be unable to do so. So it is said to be positive. Then palm print test, where we paint the patient's dominant hand with ink and place it on a white paper, and we grade it as follow. Grade 0, where all the interphalangeal areas will be visible. Grade 1, where there will be deficiency of the absence of the fourth and the fifth interphalangeal areas, and in grade 2 there will be absence of the fifth and the second interphalangeal areas, and grade 3 only the tips of the hand is visible.
In your patient, what was the examination?
The prayer sign was negative, and palm print sign, the grade was 0.
Okay. You mentioned about the autonomic neuropathy. What is it and what are the signs and symptoms and what are the tests you do to know whether the patient is having autonomic neuropathy?
It is a microvascular complication affecting almost all systems. In the CVS, we have resting tachycardia, postural hypotension, silent MI, dysarrhythmias. And in CNS, there will be syncope. In GIT, there will be gastroparesis, constipation and diarrhea. And in genitourinary system, there will be neurogenic bladder and erectile dysfunction. Then in pseudomotor dysfunction also, there are dryness of skin and anhidrosis.
What is gestatory sweating?
Fraze syndrome.
What is Fraze syndrome?
Fraze syndrome.
Fraze syndrome. What is it? Gestatory is what? Sweating is what? Over the face, over the neck, there will be swelling. There will be sweating. And when you see the food, or before you start, when you start eating, there will be sweating over the face, neck, etc. Fraze syndrome is actually a sequelae of damage while it happens in a parotid gland surgery.
You injure the auriculotemporal nerve. Okay.
So auriculotemporal nerve is involved in that. Now, what are the medications you give for the patient? For the diabetic patient?
OH and insulin. OH.
Can you classify OHA? No?
OH are classified as
What is OHA?
oral hyperglycemic agent.
Okay.
It's classified as insulin sensitizers, insulin secretagogues, and miscellaneous. Sensitizers are biguanides, which includes metformin. Then we have thiazolidinediones. Then secretagogues, sulfonylureas. First generation is chlorpropamide. Second generation, glimepiride, glipizide. Then we have meglitinides, nataglinide, and also DPP4 inhibitors, then miscellaneous SGL2 inhibitors and GLP-1 agonist.
Your patient, which OHA the patient is taking?
Metformin.
Metformin. What is the complication they mention about metformin? But it is very rare.
A rare complication of lactic acidosis seen in patients with renal dysfunction, GFR less than 45.
But it is very, very rare condition. Can you classify insulins?
Based on the duration of action, insulin is divided into ultra-short-acting insulin, short-acting insulin, intermediate-acting insulin, and long-acting insulin. Ultra-short-acting insulin includes Lispro, Aspart, and Glulisine. Then the Short-acting insulin includes regular insulin, and intermediate insulin includes isofen and NPH. Long-acting includes the glargine, degludec, and determer.
Any newer insulin you know?
We have long-acting insulin analogs, which includes determer, glargine, degludec, and degludec plus.
Okay, which is the insulin your patient is taking?
Actrapid, sir.
And it belongs to which?
Short-acting insulin.
What's the duration of action?
Duration?
Duration of action.
Short-acting insulin about 6 hours.
Okay. What are the emergency, hyperglycemic emergencies which can happen in these patients?
Diabetic ketoacidosis and hyposmolar hyperglycemic state.
Diabetic ketoacidosis. What is the triad of ketoacidosis?
Hyperglycemia, then high anion gap metabolic acidosis and ketosis.
Criteria to say that there is ketoacidosis.
pH will be less than 7.3, bicarb less than 15, and ketone bodies will be present.
What are the ketone bodies? What are the types of ketone bodies, and which ketone bodies you are testing while for the DIP test?
Acetone, acetoacetic acid, and beta hydroxybutyrate. Beta hydroxybutyrate is one strongest predictor of.
Okay. How will you differentiate these two? DKA and which is the other one?
Hyperosmolar hyperglycemic.
Yeah, how will you differentiate it?
So depending on the type, type 1 DM are more prone for DK and type 2 DM are more prone for HHS. Then plasma glucose will be more than 300 mg per deciliter for DK and more than 600 mg per deciliter for HHS. Plasma osmolarity will be more than 325 milliosmol per liter for HHS, and the pH will be less than 7.3 for DK and HHS will be more than 7.3. Bicarb will be 18, less than 18 for DK and more than 18 for HHS. The ketone bodies are present in DK, whereas it will be absent for the HHS. Then also the dehydration will be severe for the HHS and it will be moderate for the DK.
So which is more dangerous?
The dangerous is the HHS. The mortality is around 40%. 40%.
So now you will take your patient. What are the investigation you would like to do, and you should tell why you should do also. Why is it so?
We'll do a complete blood count, in that HB to rule out anemia due to chronic disease, and also if there is diabetic nephropathy. Then total count to see for increase infection or sepsis. Then we'll look for serum electrolytes, potassium level, because it will be less in and also if we give insulin treatment, and also if there will be arrhythmias. Then sodium level, which will be decreased in DK. Then we'll look for coagulation abnormalities by platelet count, PTINR. Then sugars, random blood sugars will be assessed. Then also HbA1c. Then ECG to look for any sinus tachycardia or ischemic changes. Then echo for regional wall abnormalities or any global disc.
Why ECG is an important investigation in this patient, particularly in diabetic patient?
Because there can be chance of silent MI.
Okay, so you'll not be able to recognize it, and you can see from then. Any other investigations?
Then echo and chest X-ray. Echo for regional wall abnormalities, valvular abnormalities. Then X-ray.
So, how will you proceed? What is the anesthesia plan?
The regional will be preferred over the other general anesthesia, sir.
Anesthesia plan is regional.
Yes, sir.
In regional, can you specify which one?
The epidural will be preferred over the spinal anesthesia because it gives a controlled sympathetic blockade, excellent analgesia, stress response will be blended, and also it can improve the blood flow to that peripheries.
Okay, so how will you proceed your patient?
I will pose the patient. I will pose the patient 1 day prior to the surgery, and on the day of surgery, this will be posed as the first case to avoid the starvation, hypoglycemia, and ketosis, and will convert the long-acting insulin or OHA into short-acting insulin or OHA. Then skip the morning dose of insulin and OHA, and will send the FBS, serum electrolyte, and urine acetone. Then the fluid RL will be given. Then most of the patient will be undiagnosed with gastroparesis. So NPO of 12 hours will be recommended to the patient. Then on the day of surgery, in the theatre, I will attach the patient to the standard monitors, and anxiolyte can be given. For example, midazolam, and regional technique will be preferred.
Okay, that's good. Suppose you're this patient, you're called to see in the casualty, posted for the BK, AK amputation. You find the patient stuporous, and there is tachycardia, okay, small breathing, and definitely the ketone bodies are positive. So, what is your plan? When will you take this patient, number one, and what you will do?
We'll take the patient after correcting the ketoacidosis. So first will be fluid resuscitation. Around 4 to 5 liters will be fluid deficit will be given over 6 to 7 hours. 0.9% NS will be given. Then it will be converted to 0.45% NS. Then if the blood sugars are less than 250, we can also give 5% dextrose also. Then potassium levels should be corrected. If it is less than 3, first correct the potassium, then only we can give insulin. If it is between the normal range, we can simultaneously give insulin. And insulin level, the insulin therapy is 0.1 unit per kg bolus, followed by 0.1 kg per unit per hour infusion.
Okay. So when will you take the patient? See, ketone bodies was positive,
Yes.
right? So when will you take? What are the criteria for that?
Sir is asking
reversion.
Sir is asking whether you will wait for ketone bodies to correct.
No. After if the pH is within normal limit 7.3, bicarb is more than 15, and the ketone
Anion gap is also less.
less
Okay.
normal. Okay.
So why not ketone bodies? Why don't you wait till the ketone bodies is negative?
Because beta hydroxybutyrate takes time. It takes time.
So how much?
6 to 12 hours.
12, more than 12 hours. So that is not the criteria to take the patient. You can, after fluid resuscitation and once the sugar comes down, you can take the patient. So you said this patient you will give regional techniques. Suppose you find in the echo that the ejection fraction is less than 20%. Okay, and in the echo there is global hypokinesia. So, what is your plan?
The AF of less than 20% and global hypokinesia itself is a high risk for the surgery. Here we need to avoid the myocardial depression and maintain the hemodynamic stability. So regional technique, preferably peripheral nerve block can be given to the patient. So if we are planning for AK amputation, we can give sciatic nerve block. Combination of blocks can be given.
Sciatic block, can you be more specific? Which part of the sciatic now? Where exactly?
Subgluteal approach.
Subgluteal.
Then
why not popliteal? Popliteal also there is.
It is more preferred for the BK. We can give for the BK.
Means you will have to give higher up.
Higher levels.
What else?
Then we can give for AK amputation, we can give a combination of sciatic nerve block via the subgluteal approach, femoral nerve block, obturator nerve block, and the lateral femoral cutaneous nerve block.
Okay. You do under ultrasound? Landmark?
Yes, ultrasound guided.
Yeah, it was done under landmark technique also. All this, when we were young, it was all landmark technique. But now you have the ultrasound, and that is a luxury, and it is easier to do it, and even the nerve injury is much lesser. Now you completely will shift from this case to another case of a diabetic patient who has come for a laparotomy for a DU perforation. So how will you proceed? What all you will do, investigations, you will see the investigations? Okay.
Then we'll connect to all standard monitors. Then I'll prefer GA.
What are the standard monitors used?
NIBP, ECG, pulse oximetry, heart rate, ECG, temperature
Okay,
and
temperature. Okay.
urine. Then I'll prefer GA.
You mentioned it is CO2 also?
Yes, it is
Yes,
CO2.
okay.
I will prefer GA.
You
then I'll
prefer GA, general anesthesia. Yeah, okay.
Then I'll pre-oxygenate the patient, and anxiolytics, benzodiazepines can be given.
Anxiolytics, is it important?
Yes.
Anxiolytic, you mean to say that on the previous day or you will give anxiolytic? Is there any advantage of giving alprazolam? It's an anxiolytic.
Yes, we can. It will decrease the sympathetic response.
Yes, so the hyperglycemia part will not be there. Yes, good.
Then I'll prefer etomidate.
Induction agent,
Induction agent, etomidate.
Why not propofol?
Propofol, it will be difficult for the diabetic patients to excrete because it is lipid containing. So
Okay.
excrete from circulation, it will be difficult. And also ketamine will cause hyperglycemia. So etomidate will be the choice.
So ketamine is also not a choice. Etomidate is a choice. And
And high dose of fentanyl can be
because
used.
of gastroparesis, will you take any precaution?
Yes, where RSI technique will be used. So
What is
rapid,
RSI?
rapid
RSI
sequence
or
induction.
modified RSI.
Which one you will use?
A modified RSI.
What is the difference?
We use rocuronium instead of succinylcholine.
Okay, what is the problem? Why not you use the one, not the modified one? Why don't you use choline?
Because it can cause transient hyperkalemia.
How much of potassium can increase?
0.5 million.
0.5. Yeah, but still it will matter. So it is a rapid sequence intubation you will do. So intraoperatively, how will you manage? What is the level of the blood glucose you would like to maintain?
Around 140 to 180 milligram per deciliter.
180. Have you heard about tight sugar control?
Yes, sir. It means between 70 to 110 milligram per deciliter.
And which type of surgery do you prefer?
Major surgeries like CABG. Because
CABG. Why in CABG?
Because of hypothermia, it can increase.
Okay. So in those, you are right. Absolutely right. Extubation part. Will you extubate this patient or later? It's a laparotomy. There can be issues with breathing, and there can be atelectasis also. So yes, what are the postoperative complications? Which can occur, postoperative complications?
Postoperative complications seen, metabolic complications such as we can see hypoglycemia, hyperglycemia. Then type 1 DM patients will be more prone for DK. Type 2 DM patients will be more prone for HHS. Dehydration, then metabolic electrolyte imbalance, which includes hypokalemia, hyperkalemia, and hyponatremia. Then poor wound healing, then DVT or pulmonary
A
embolism.
good pain control should be there. Otherwise, what can happen in this patient? There can
will be
be
increase in the
a
sympathetic.
silent MA can occur. So it is equally important intraoperatively and postoperatively, and then we'll have to manage the sugar. It's almost 2 minutes now. Now I will allow your internal to ask question. You have done very well.
I want to give some other corrections there. When sir asked about the newer insulin, better answer may be inhaled insulins, Exubera, Afrezza, and Technosphere. That you can tell. Then regarding the decay management, the better answer may be FRII, that is fixed drug IV insulin infusion regime, and in others, like sir asked about the laparotomy, you can tell that variable regime, IV insulin infusion, I will go. That may be the better answer. Okay, I think they have done.
Yes, you have done extremely well, and the message to the postgraduates, it is actually what you have to understand is India is the capital for diabetes. That is what you have to know. Almost 12.5% of the population are diabetic. And this surgery, this especially the amputations, they say that yearly almost more than 50,000 amputations are being done here in India. And there are no the PG senior people, but I'm sure that every anesthetist would have done this case. So you will definitely have to know about the diabetes, about the condition, what can occur, the complication, etc. Thank you very much. Thank you, Osric and Christy. Done extremely well. Thank you. And thank you for the internal, he has taught you well also.
Thank you for enlightening us on this topic.